Okay. Fine.
In 5, 4, 3, 2, 1.
Good evening, everybody, and welcome to this meeting of the Health and Wellbeing Board, which is taking place today, the 5th of May, 2021. And welcome to all those who are watching us on the web, because this is live broadcast, and anybody that watches us afterwards. So far, we've received apologies from Mike Padgham, and I see Beverly Proctor subbing for him. Welcome to her. Alison Simmons has sent her apologies, and David Harborne is here. Welcome, David. Sian Balsam has sent her apologies, and Janet Wright, welcome to you, and you will be joining as her substitute, but joining the board in your own right before too long. We do know that a couple of members may have to leave by about 5:30, but hopefully we'll have got through the business that affects them before that. Please, can I ask if anybody has any particular declarations of interest that they haven't previously declared in items that are on the agenda? No hands that I can see. Good. Then next, it's the minutes of the previous meeting. We do have some reports of the actions that have taken place. So first of all, may I accept the minutes as a correct record? No objections. And then, Tracy, would you like to bring us up to date with the actions, please?
Just get my camera up and running, and my
it's the care home deaths that are the important ones.
Okay, so I think this was a follow-up from the previous meeting, and it's more of a clarification rather than an action around a comment that was made in relation to deaths in care homes in York. And we did circulate this after the meeting, but for the record, for anybody listening on the webcast, I just want to read a short piece that clarifies what was said and makes a slight correction. So the reported figure for deaths in care homes in York via the Office of National Statistics is 128 to date. That's the date of the last meeting in March, slightly higher than the reported figure by homes. There is always a slight discrepancy as ONS counts some non-care home settings. Given we have 1,524 registered care home beds in the city, this would equate to approximately 8% of total bed capacity, so nowhere near the third that was originally quoted. Also, that is beds, and more people would have been through the services than that number during the year. So the actual figure of residents would be even lower. So I think that's just some clarity, because there was some confusion over what was said at the last meeting. And I don't know if any of the board members need to make any further comment on that.
Thank you very much, Tracy. Councillor Craghill, did you want to say something? No, she's disappeared.
No, sorry, I just tried to unmute. Sorry, Chair. Yes, it wasn't about the care homes. It was about another item on the minute. So is that, are you ready?
Yes, if you wish to raise it now.
Yeah, it was just about the item on page 3 under public participation about Vocare and the urgent treatment centre at York Hospital. The action recorded in the minutes is to pass the issue to Health and Care Scrutiny Committee. And I just wondered, I just wanted to ask firstly if that has happened and when they might be looking at it, but also just because obviously there's timescales involved with this. I just wondered if anyone present on the board could update us any further, as there did seem to be a feeling that perhaps from a number of quarters that perhaps this service could be re-provided within the NHS. And so I suppose the second part of my question is whether anyone can update us since the last meeting.
Councillor Perrett, before I ask Simon to come in.
Thanks,
or Nigel.
I was just going to say I do sit on health scrutiny, and it was on the agenda for Tuesday the 13th of April. I couldn't be at that meeting due to work commitment, but I would assume that as it was on the agenda, it was discussed at that meeting.
Right, I hadn't checked before.
Thank
now,
you,
do we know any
Councillor Perrott.
outcomes?
That's very useful. Yeah. Simon Morritt, is there anything you want to add to that?
Well, I think, Stephanie, I wasn't at the scrutiny committee meeting, but I know that Stephanie Porter was, so she should be able to give an update. I mean, I would just reiterate the point that I made at the last meeting, which is to say that there has been no change to the services that are provided from York ED in terms of the provider of those services. So the minor illness services that have been provided by Vocare since 2015 continue certainly until the 1st of April 2022. It will be a question for commissioners to determine what happens beyond that date. The challenge that we were faced with was becoming compliant with the specification around urgent treatment centres, which we have now been able to achieve. So we've been able to find a way of effectively meeting the requirements of that specification without making any changes to the service providers from the front door at ED. But I'm sure Stephanie can feed back on what happened at scrutiny. Thank you, Councillor Unson.
Yes,
Stephanie?
thank you. We had a long and detailed conversation, and it focused in on a couple of the questions that were very specific. So firstly, we were able to give assurance that staff from York Emergency Department were not 2Ping to Vocare. That seemed to be a particular concern, which we were able to clarify that was not the position, and both Vocare and York have previously made written statements to that effect. And in the same vein, the concern expressed that there was a increase in the privatisation of the services in the emergency department. And just to reiterate what Simon's just discussed, both providers and commissioners are committed to maintaining the service that we have with the plurality of providers, because that's actually, it is working well. There is no increase, no additional services being privatised. What we went on to talk about was the continued engagement with the primary care community, our GP community, with both the hospital and Vocare, to work together over the next 6 to 12 months on responding to the patient voice and improving the service. So making access easier to understand, the range of ways in which people would get same-day urgent care, not through the emergency department. And we did talk about the different language that the NHS use. So we'll continue to work together as a health community on both the compliance issue, but also addressing the improvements that urgent care need to make to meet the response that we'd heard from patients about making access easier to understand.
Thank you, Steph. Thank you, all three of you. It's good to know that it went to scrutiny. It's good to know that scrutiny spent quite a time going through it in detail, and it's good to know that it will continue to be looked at. So that's very helpful indeed. Thank you. Are there any other matters on the minutes? No? So can we accept them now and go on to agenda item 4? And agenda item 4 is the paper on page 11 about the Mental Health Summit, which Tim Madgwick and Phil Metham are going to introduce. So can I hand over to one or both of you, please?
Yes, thank you, Chair. If I can start, and then I'll hand on to Phil. members of the board will have seen the paper, and I don't intend to go through it section by section. To summarise the starting point, we saw as a wider mental health community considerable demand for the city, but not that's not out of keeping with the national picture, I believe. Although, but across a range of services, and both Phil and I felt there was an urgent need to get sectors of the community or sectors of the those providing service together quickly to see what we could do in relation to a short, medium and long-term plan for the city. In the same way that the city responded to the actual COVID pandemic in the first place, because we saw the scale of demand hitting primary care and others as great, but it was in a more, I wouldn't say understated way, but not quite getting the publicity that obviously the main pandemic raised. So that was the motivation to see what we could come up with in terms of a commitment to maximise the service and maximises the ability of people who are working incredibly hard in the city and the agility that the city showed when it responded to the pandemic over a year ago. So we were, I think, delighted at short notice to get the sort of response we did from key partners, leaders across all sectors. And we had a series of presentations from, you'll see on page 2 and page 3, experts in their field, from Public Health England, Tees, Esconway Valley, and we go down that list. So they all spoke in some detail, but it came to the same conclusion, really, that although there were estimates of demand last year, so May 20, we've still got demand, and it's not quite as great as the first estimate, but it is significant. And it's interesting, even today, this morning, I've listened on the Radio 4 to what the latest figures for depression are across the country. Yes. And they are quite startling. So we agreed we'd split the session up with the presentations, then look what we could do in the short period, medium term and the long term. And I think if I just drew members' attention to the sections, which was 17 and 18, and if you look down at that list there, it's telling those are the areas we're seeing considerable concerns about. It doesn't know there's lots of other areas, of course, but we're seeing those concerns, and they were also, some of those were reflected this morning, interestingly enough, on Radio 4, the issues about young adults, women being more affected in some areas, and the list goes on. So we called it, and we got that response, and then we got a piece of work which we were determined to get as a result, and this is the reason for bringing it today, is commitment from the leaders across sectors to commit resources to try and respond appropriately in the short term, medium term and long term. And including the public and the private sector, looking at how we could engage employees. And then we've got the action plan that we're setting out, and we're meeting on a bi-weekly basis at the moment. We feel passionately that if we don't respond appropriately, we'll be letting sectors of the city down, and we'll be letting people who are disproportionately affected, either through their personal situation or some other reason. We won't be offering the best possible deal we can. We fully recognise there are massive pressures. We fully recognise there are difficulties in recruitment in some of those areas. These aren't easy questions to resolve. I'll hand over to Phil. What I would say, I'm very grateful for what we've seen to date. What we have to now see is that followed on through the rest of this summer and the rest of 2021, because that's the important reason. That's the reason we had the summit in the first place. Phil, if I hand over to you now.
Thanks, Tim. Hi, everybody. Good to be with you this afternoon. Emma, I'll just carry on if that's all right with you. That was a great exposition, really, Tim, of where we've been. So I'll not take much time to add to that, other than to say we were really clear that we are facing an unprecedented situation now and going into the future, and resolved that if we were to work in our more traditional ways, then we would not be able to respond to the not only the demand, but the changes in the profile of that demand that we are anticipating. So we resolved that we had to do something different to be able to change the service offer for our residents. And so my role in that was to facilitate at relatively short notice a discussion about how we come together and collaborate to create a more responsive and bespoke offer. As Tim's outlined and as the paper demonstrates, we have a basis of actions that set that out for us. My role now alongside Tim will be to hold leaders within the city to account for their commitments that they made in that summit and as Tim described, going forward over the next few weeks and months, both in terms of making sure that we can start to respond through the summer in some specifically focused areas, but equally be clear how we get through the winter ahead of us and we go into next year and we work out in 3 years-ish time what service offer we think will be more appropriate to what we're facing at that point. And so as Tim has done, I would also reiterate my thanks to everybody who responded so quickly. We had just about everybody you would want in the room. We had the commitments that you would hope to receive, and we're now determined to make sure that those commitments are honoured in our actions. So I'll just pause there. Happy to take any questions or comments. Carol, thank you.
Thanks very much, Phil and Tim. I noticed Emma had her hand up earlier. Emma, have you still got a question to ask?
Yeah, thank you, Chair. Yes, well, firstly, I just wanted to probably apologise and explain on behalf of primary care at short notice. I'm afraid we couldn't release a GP to come along, but just obviously to reiterate primary care's commitment, because certainly it is our second commonest condition now presenting to primary care is mental health. It used to be fifth. So this is something we're living and breathing in primary care very much. I just really wanted to bring up one point that was really helpful, because it was discussed at the Health and Wellbeing workshop that we had last week. We can't create mental health workers out of the air. We can do the training, and as Phil said, there's a 3-year programme. But I think the most encouraging thing I would want to feedback from the workshop last week is York has a fantastic set of community assets. And one of the things we looked at is how we can bring those assets to the fore. So we're aware domestic violence rates are up, eating disorders in children are up. We're aware of so many of the factors that are contributing to mental health, but actually some of the really simple things, some of the groups, the walking groups, the social interaction groups, the groups that are dealing with loneliness, they're out there. How we link them to those in need. So I felt very encouraged that, as well as the long-term strategy that I read obviously from that board, I think there are a lot of community assets if we can join up the work that I know Peter Roderick's leading on from public health. So the public health resources and those that are available to the council, to the residents, we may prevent some of the progression and just help give us the airspace to create a more resilient system in the 3 years. So I just wanted to share that optimism that came out of the workshop.
Thank you, Emma. And just for the record, and I may have said it before, York St John will be offering a nursing course in September with a public health specialism option in it. And anything like that is contributes to our sum of people quite significantly.
Chair,
anybody else like to ask a question or make a comment? Tim?
Chair, could I just very succinctly respond to Emma in the sense that what we have seen through the Community Safety Partnership is a programme which is currently called the Northern Quarter Project, which is basically about community mental health and exactly the ethos that Emma described. And as part of the CMHT funding process that's going to roll out over the next 3 years, we will see that roll out across the entire city. And that basis recognises the exact point. We can't, unfortunately, magic experienced mental health specialists out of thin air. We've got a community with a huge range of assets. And our job, one of our jobs, is to try and maximise those assets in any way we can.
Thank you, Tim. Any other comments or questions from anyone? Denise.
Thank you. Yes, just wanted to start by saying that it looks like a really, really good and positive action plan. And I suppose my question is linked to that. Some of those actions are absolutely, you know, really good, ambitious and absolutely right, such as extending the northern quarter to the whole of the city and developing a system without thresholds. I might have expressed that not quite rightly, but I think that's what it says. I just wondered about what the process is going to be for reporting on progress and how we're going to do that. Really, I hope you know, really hope we can. But they are very ambitious, aren't they?
Thank you.
Rightly so.
Tim?
Yes, well, the mechanism will be part of that already through the Community Mental Health Partnership, and that will report back and can report back to this committee when required to. We will do that as and when required. It is ambitious, but the whole commitment from Phil and myself, but also more importantly, the colleagues, some of whom are on this call today, was ambitious in the sense that we had to be ambitious. We didn't feel it was satisfactory to say, oh, well, we'll try and do a little bit better. And the good thing is that at least across the ICS and the region, people are recognising some of the work that's been undertaken in York. Some of them have significant challenges involved, but that, yeah, I think that again applies to every mental health programme in the country. I don't think there's anyone who'd say they've got all the resources they need. What I would say is we have the potential to turn that action plan into reality. And I think that's the important thing, because we got the commitment from key leaders on that day, and we, Phil and I, intend to do our level best to hold people to account in a positive way, not in a negative way. It's about trying to get the level best we can for people across the city. So through the Mental Health Partnership Chair.
Councillor Perrott wants to ask a question, and then I'll bring in Amanda if she'd like to make a comment. Thank you, Councillor Perrott.
Thanks, Chair. I was also going to ask, I was a bit curious about the thresholds, so good to know that me and Councillor Craggill were on the same page with that. But I suppose my question really is about the level of unmet need that there already was, because obviously if, as it says in the report, we've got around 20% of the population expressing either increased need or previously unmet need. I suppose it would be interesting to know where the pressure points are currently. Is it in primary care where, sort of, as Emma had said, people are sort of coming in more commonly, or is it a little bit sort of further on with other services? It'd just be good to know where people are sort of making that first request for help really across the system and what the pressures are.
Tim, can you help us?
I can to a degree.
Okay.
I recognise a lot of experts across this picture that I'm looking at, but there we are. I think we certainly echo the points made about primary care, and that we're getting that reported to the partnership. There is an increase in relation to primary care, but we're also seeing acuity and speed of acuity from unknown presence in the first place. Eating disorder issues, which are a key part of the CMHT response, but eating disorders are there. So I think there's pressures across every area. One of our concerns, and if I can partly answer the threshold question was that, you know, there is a sense that certain individuals who are near that threshold but don't, you know, reach that threshold, don't get a service or don't get a response. We're trying to address that issue in terms of what sort of response they get, as opposed to being left out of any sort of response or care. So it is across every part of it. But those I think, you know, from colleagues on this call and others, they've raised those as a key priority. But there are many others as well, and you know, the mental health partnerships will continue to monitor all those and try and support in the way that I just described. But unfortunately, the only touch of reality is we haven't got a magic wand. Unfortunately, we can't do some things without certain resources. The good news is we are getting our fair share of CMHT money that is coming into the city, and we will be well placed to use that money through positions that haven't been filled before but are being filled now, and some of them have already been filled. But yeah, as I say, we're not ducking any of the challenges, and I'm sure it'll be unrealistic to say to you as a board, we have all the resources we need, because clearly we don't at the moment.
Thank you, Tim. I'll ask Amanda to comment, and then I'll ask Naomi if she'd be so kind.
Thanks, Chair. I think Tim and Phil have pretty much said it all. You know, we clearly know that mental health need is rising as a consequence of the pandemic, and I think there's a really strong and ambitious action plan in relation to what we can do as a system, because none of us have got the solution to this on our own. So that kind of joint working is really key.
Thank you, Amanda. You're absolutely right. Naomi, would you like to comment from your perspective?
Yes, thanks, Chair. I did want to come back particularly on the workforce challenge. We know this is a challenge just for this area, but it is a national challenge in particular. And I just wanted, I suppose, to share with the board that we are working as TUBE, and mental health workforce is not exclusive to TUBE, but we are working very closely with our partners in the York area and education sector to look at the pipeline of workforce and creating the courses that you've already mentioned, Chair, with York St John. So we're looking at new nursing courses, there'll be a new social work course as well, and we're already supporting the Think Ahead National Programme for Mental Health Social Work, and across North Yorkshire and York, we're extending that cohort in this year. So generally, we're trying to increase the capacity of mental health professionals across the area, which will hopefully serve us over the next 3 years, and also looking to other roles that could come in and support across the whole system in mental health to deliver care where it's needed. I think, as Amanda said, I think Tim's probably summed it up very well. We've got the community mental health framework and transformation that is planned over the next 3 years, and the principles of that, which are about looking at thresholds, reducing the gaps that we know were in existence between primary and secondary care, and also working much closer with our partners, for example, in children's services around, you know, our universal care to children in education through to really complex young people that challenge us all, and we will have to work in a very different way to meet their needs. I think it's really exciting, and I think York is actually very well placed in terms of its partnership and the work it's done so far.
Thank you very much, Naomi. That's the perspective from TUBE for our mental health providers. Is there anybody else who would like to comment on or ask a question before I bring this item to a close? No? Right. Thank you. Tim, I just want in conclusion, I'll give you the last word, obviously, to say that I hope that as the country opens up again, all the very local provision for just making friendships with people will come back into play. All the local chat cafes, as it were, I think they do such a good job at a very low level in picking up mental health problems that are not as serious as needing to go to TUBE. And I think they play a very valuable role. And before I go to the recommendations, would you just like to make the last remarks?
Yes, I would. I think the preventative element of this piece of work is huge, because we recognise that services out there are stretched, and loneliness and aspects of how communities engage with individuals is critical. So I think I would echo your thoughts, Chair. As things start to hopefully improve bit by bit, yes, putting people in touch with local enterprises, local individuals, anything that will will break down that loneliness cycle will be significant. And that's to a degree why I am optimistic about some of the things we can do in York, because I think there is a sort of a template there that can address some of that. It won't be for everybody, but we recognise that that's one of the answers, and one of the big answers. You're right, Chair. But we can't let just people become more acutely ill by not trying to maximise that. Yeah. So that's it for me, Chair.
Lovely, thank you. So just to remind members that we've been asked to note the report, which we are clearly doing, and it asks us to ensure that adequate resources are made available within individual organisations to progress the actions within the timescales identified in the action plan at Annex A to this report. So I suggest everybody reads Annex A to this report very carefully, and unless there's anybody dissenting, I think we should accept those recommendations. Lovely, thank you very much, Tim, and thank you, Phil, too, for the work you've put into that one.
Thank you, Chair. Thank you.
Thank you. Now we go on to agenda item 5, and I've realised that I didn't say we didn't have any public speakers at this meeting. We were hoping to, but unfortunately nobody could make it. So this is the Ageing Well Partnership report on page 25, and it's going to be introduced by Nick Sinclair.
Thank you, Chair. So hopefully everybody's had a chance to read the report. I won't go through it in any particular detail really. I'll just pick out some key points. But I suppose the report is submitted to the board to note and consider and give some direction, or give some thought and acknowledgement on the direction of travel that the Ageing Well Partnership is moving down, and to ratify the terms of reference for the Ageing Well Partnership that have recently been reviewed. So the report really is a summary of the work that's been ongoing within the partnership over the last year, and I think important to acknowledge that there was a little I suppose lull in meetings and progressions of priorities around the time of the COVID pandemic, and that's led to change in chairship, which is now jointly chaired between myself and Lisa Marriott in the Vale of York CCG, which is a really positive move in terms of creating collaborative working and links and connections to the York Healthcare Collaborative and a lot of the work that's going on in CCG. The partnership is, as I say, now included or has a bit of a broader membership with a bit more inclusion of community and voluntary sector representation, and in the terms of reference that is in Annex C will also acknowledges the need to ensure that engagement is part of the process within the partnership, and that there's an expectation of active involvement by all the members of the partnership. And in terms of the priority work streams, the partnership is very much sort of led by the review of priorities that the Health and Wellbeing Board undertook in sort of mid-2019, and pursuing that through 3 priority areas: the age-friendly community work, which is progressing well and is attached to the aspiration to become an age-friendly community and achieve that status through World Health Organization, progressing that through 5 domains and 5 themes, which some of the detail of is in Annex A, which identifies progress against those domains. Getting out and about and your time and your information are the domains sort of currently under progress, and the action plan is reviewed regularly. The Ageing Well Partnership, and the partnership is really pleased with the progress it's making. It's a really good and positive piece of work that's achieved quite a lot already. There's an age-friendly citizen group that's been re-established, which is very engaged in the process of this age-friendly community status. And the work of that group is now sort of reported regularly on sort of progress on a page, which gives people a really good insight into what they're doing. Some really good practical initiatives that have come out from that piece of work as well, like the Chatty Bench initiative, which was supported by Good Jim, who kind of ran across the whole city and tracked which benches were available for use by people, and Chatty Bench sort of being there to allow people to have a conversation, out in the open with people, so that they could feel a bit more connected to the community, and as well recently provided a blog to the Centre for Ageing Better, which was written by the chair of the Age Friendly Citizen Group, and that was to mark the UN's decade of healthy aging. So lots of really good engaged work and progress in that bid for age-friendly community status. And then the second area of priority is around the dementia strategy, which is detailed in Annex B, and is on a timeline to produce a strategy for September of this year. I think important to recognise that there was a bit of concern and frustration about the perceived delay in the creation of the strategy according to the initial timelines. But I think we've now got to a place where we've got a really good action plan and timeline in place, with a working group that's met and has agreed priority areas and identified some gaps that were there in sort of previous strategic direction, and is on target to get that strategy produced for September. And then finally, the third priority area is to pick up on a piece of work that's very much connected to COVID and the impacts of COVID around deconditioning in older adults, and beginning to start production of a campaign really to focus on deconditioning, the importance of physical activity as a prevention measure to stop deconditioning, to stop the impacts of frailty and reduce things like falls, and basically just to try and increase the health and well-being of our residents by encouraging that physical activity and reduction in deconditioning, which has a wide range of physical health conditions. And then I suppose finally there's a bit of there's consideration of other work programs and themes that the board has been looking into, and I guess just want to acknowledge that given the pending future development of a new health and wellbeing strategy, I think it's important that the Ageing Well Partnership is engaged in that process and helps to kind of shape what those priorities for ageing well in the City of York need to be. And I think I'll probably leave it there and open up to any questions if people have any.
Thank you, Nick. That's very helpful, and it's good to know that the partnership is moving things along, particularly in the area of the dementia strategy, which has been sitting on the back burner a bit of a while. Right, any questions or comments to Nick, please? Right. First of all, Dr. Wells, and then Councillor Perrott.
Thanks, Chair. Thanks, Nick, for that. I just wanted to pick up on the deconditioning bit. I thought that's a really interesting part of a bit of work. We know that there's a lot of people waiting for procedures and operations, and that's expanded a lot with COVID. One of the issues that we'll come across is optimizing people before their procedures. So something like deconditioning and getting into this conditioning work is really, really important. So it's just to make that comment and to say I welcome that. So thank you.
Thanks very much, Nigel. Anna?
Thanks, Chair. Thank you, Nick, for this report as well. It's really good to see all of these actions, and I completely agree with the Chair that it's good to see that we've got a lot of progress towards getting a dementia strategy in place, because it is something that we've been hoping for a long time for the city. So thank you for that. And I was going to ask just whether or not the older people's survey could do with a refresh, sort of in light of COVID, because obviously between 2017 and now, a lot will have changed, and I know it was a really useful piece of work to help us design services. So is that something that could potentially do with looking at again, sort of in light of what's happening differently? And if I may just ask one more quick one, just about the timescales on the Age Friendly York project plans. So getting into Domain 5 sort of brings us very close to sort of the end of the point for submitting things. And obviously if it's looking at services, sometimes change can take quite a while to implement for services. So is that something that could potentially be looked at sooner if other domains make progress? It's just, I don't want to be cynical, but it does sometimes take quite a while, doesn't it, to sort of identify what services are available and what the changes could be. And it just feels like having that one at the end might be sort of missing a trick if we're then pushed for time to be able to submit to get the status on time in line with that plan.
Thanks, Anna. Nick, can you respond to her questions?
Thanks, Councillor Perry. Yeah, really important points and questions. And in terms of the older people's survey refresh, I think there's a piece of work to do for the partnership to determine what its priorities are and how that links into the Health and Wellbeing Board strategy. So that's absolutely on the table. I guess I would just say that as part of the age-friendly community work, the initial steps for each domain are to kind of do a lot of that engagement and do some of that surveying, so that it is informed by the views of local residents. But whether or not we need to run a fuller survey from a more general perspective, we can certainly consider that at the partnership. Hopefully that's assuring. And then, yeah, your point about the domain timelines is a really good one. And again, I suppose part of the setup for those domains is to doing some of that sort of pre-work and understanding what the issues are. So we can certainly follow that up at the partnership and see whether or not we need to consider moving some of that work forward, so that we're not pushed at the end and risk not having the right information that we need to submit the application.
Thank you. Peter Roderick next. Peter is here subbing for Sharon Stoltz, who was called away at the last moment.
Thanks, Chair. Yeah, I mean, just to again echo thanks to Nick and Tracy really for the report, and to Lisa as well. I think, especially given the context of COVID over last year, it's great to see that the work of the group has got started again. And there's some really key pieces. I would echo Nigel's comments around deconditioning, and generally, similar perhaps to the previous item on mental health, that a lot of the ways in which lockdown has hidden things away, we are about to see some huge health issues away from pure COVID directly that are coming. And I think, older people's mobility is another one of those. And then just a comment really on, and I guess a part of the age-friendly work really being around perception. And I think we've done a good job through the age-friendly work of the perception of valuing older people as members of a community, and the assets that they are, and the things that they bring to our city. I think there's also something about not losing hope around the prevention agenda, and particularly some really recent sort of work quite firmly establishing the link between dementia onset and tobacco use and smoking, which previously we associated tobacco and smoking with a lot of other diseases, and only recently dementia has become quite key in that. And actually, it's never too late to quit smoking. It's never too late to do those standard public health things, which we maybe sometimes restrict in our thinking to people of a younger age. So I think there's definitely a piece of work in terms of that real link into prevention and some of the public health services we offer. So just want to note that as an opportunity. And I think potentially do more through the health trainer service in New York to make sure that we are targeting the work we do to all ages and not simply people sort of lower down the spectrum.
Thank you, Peter. Denise, Councillor Craghill, next, please.
Thank you. Yes, it was just quite a specific point. I mean, just in general, just to say there's so much really good things in here, and so much connecting of things together, which I think is something we're doing really well. It's good to see. I just wanted to ask about, there's a mention somewhere in here about the intergenerational work that we've done to incorporate intergenerational elements into the housing delivery programme at Ordnance Lane, and it just made me think that in terms of who's involved, the whole sort of older people's programme in the council and housing delivery, are people involved from that aspect? Because it is certainly something that we are actually taking forwards.
Nick, do you have an answer to that?
Yeah, I'm not particularly close to that piece of work to know all the detail about who exactly is connected, but I think you're right in your observation that there are a lot of those connections happening, and the age-friendly community work is really positive in bringing and making a lot of those connections by pulling together people from different parts of the system to work on those particular agendas. So yeah, I know there is a lot of kind of collaborative working, but as I say, I don't know the ins and outs of the detail of who's actually working on which areas and how, but that is, I suppose, one of the underlying principles behind the age-friendly community is to bring that collaboration in.
Yeah,
Nick, you can take that away and have a look at it, and perhaps let Councillor Craghill know if you find out there's a particular person she could talk to.
Yeah.
Yeah, thank you. Emma?
Thank you. Yes, I just wanted to bring up, obviously, to thank Nick for the report. It's really helpful to know what's happening. There's a very helpful thread that Lisa Marriott, who works on the York Healthcare Collaborative that I chair, is obviously on that committee, because she's responsible for, unfortunately, a similarly named initiative called Aging Well, which is an NHS strategy that involves increasing funds to try and address healthcare responsiveness to needs for our housebound and elderly vulnerable cohorts. So the ability to respond to a patient who has a fall and put interventions in place, so that preventative work that Peter touched on. So it's very reassuring to see that she's going to be the thread between supporting the age-friendly element and the aging well health element. So there's those two big initiatives. I would just probably want to reflect again, as a local GP, it was quite something to be doing the home visits. So we were doing a lot of home visits to deliver the COVID vaccinations to those who were housebound. And it was very humbling to meet a lot of our nonagenarians, centenarians who, it was a real stark reminder, have not left their houses for, in a lot of cases, for over a year. So their social interactions have been really through windows, through sort of minority care, sort of carer system. And I guess I really look forward to the age-friendly initiatives engaging again with our housebound patients, because many of these patients were attending the day centres and having regular social contacts. Of course, through COVID, have lost those. So there's a lot to say of really remarkable people living at home with very minimal social contact that I hope Aging Well can really start to address, getting some of those day services up and running now that they're vaccinated, and that sort of age-friendly initiative can address. Thank you.
Yes, thanks, Emma. I'm sure that they were as pleased to see you as you were as pleased to see them. Any more comments or questions? Right, we've got some recommendations to consider. We need to ratify the refreshed terms of reference at Annex C, just to note that they're not very different from what they were before, just slight changes, and to indicate our support for the direction of travel for the Aging Well Partnership. And you've seen the priorities, Nick's made them very clear: developing a dementia strategy, progressing the age-friendly York project, and further work around deconditioning, which Nigel particularly mentioned. Just to add, I did ask, I was a bit startled to see that Good Jim had run every street in York when I was reading the papers before the meeting. And I asked for some clarification. Apparently they've run every street inside the outer ring road, and their plan now is to run every street outside the outer ring road. So I think that's very impressive, and we have to send lots of thanks to Good Jim for their hard work. So unless there's anybody wants to make any particular comments about that item, I'd like to go on to the next item. And Nick is going to update us. Oh no, it's Peter, isn't it? Peter's going to update us about the current situation with COVID-19 and COVID recovery, because Sharon Stoltz, as I said before, has been called away. So Peter, it's you.
Thanks, Chair. I'll share my screen with colleagues. And just to check from somebody, if possible, that that's showing for everyone.
It is.
Thanks. Thank you. So I'll just take the board through some of our most recent data on COVID and some of the case numbers that we have. Oh gosh.
Got them all.
We've got them all at once, not what we're expecting. So as of today, or rather the most recent data, which is always a couple of days behind for the testing to be validated, we had a rate of 17 cases of COVID-19 per 100,000 in the city of York. And that was over a 7-day period. That equates to 36 cases in that 7-day. That's the most recent provisional rate. And what you'll see when you look at some of the national data, that rate is probably most likely to say a rate of 21.8. The national data is just a little bit behind the provisional rates that we put out, and that equates to 46 cases. And that's actually a positive, because it means that the cases that we can see are more recent, there's a lower rate than in the cases that are a little bit behind. And as you can see from the graph on this slide, the red line representing York, you'll be aware that in wave 1 April last year, case numbers seemed low because testing was mainly for those who are hospitalised with COVID and not in the community. Since last summer, when testing has been more widely available, we've had a large peak in October in York, and getting down in mid-November to around the 60 per 100,000. Obviously, over Christmas, in line with national and regional trends, that accelerated, and we got over 650 per 100,000 in the early January period. Since then, an equally sharp decline, and York rates have gone down to the point at which we've been one of the lowest in the country. We're second lowest in the region now at 21.8. We've seen a little uptick in rates over the last 2 weeks in York from a low of around 10 per 100,000. That's timed to coincide with the April the 12th changes in the roadmap, and a little bit more mixing, as in we might have expected to see a little bit of that, but it's been really rather small, and actually given the small numbers, could just be a chance fluctuation really in the rates, not really a taking off, we don't think, of any new wave, and we would have always expected case rates to rise at this stage, and we're also looking obviously at other factors as I'll explain later on in terms of hospitalizations and deaths. These are our over 60s, and as you can see, a similar pattern and a slight uptick recently. The most recent week, we've seen 6 cases in those who are over 60 of COVID-19. Our positivity rates, the proportion of the tests which are coming back as positive, this graph will show the York rate, it will show the regional rate, and it will show the England rate. And that's for the tests which are for those who are symptomatic, so PCR tests. And as you can see, about 1 in 100 tests at the moment are coming back positive in York. And that's broadly similar to what we're seeing nationally, and it's lower than what we're seeing regionally. And we're certainly surrounded by some areas regionally where we have what we are terming enduring transmission, so stubborn rates which have not gone down in line with national trends. Leeds, East Riding, Selby directly below us has seen higher rates too as a district, and we have much lower positivity rates than those areas. And when we think about the tests that we're doing, which are probably the largest number of the tests every week, which are lateral flow tests, the number of positives from lateral flow as a proportion of all tests is again lower, and that's because those people are asymptomatic when they take the test, a lower likelihood of them being positive at the time that they take that test. And as you can see there, sort of 0.1% of those individuals, 1 in 1,000, are testing positive. There has been a small uptick in the number of people who are being reporting to NHS 111 and are phoning 111 with a COVID query, but that's in line with what we've seen. It's been a little bit up and down. As you can see, the line wiggles a little bit ever since it's come down in early February, and there's nothing there to indicate that we're seeing an upswing hugely, but we do keep our eye on this indicator because it is something that might tell us that we're about to see an increase in cases. This slide talks about, as of the 27th of April, there being 6 people with COVID in general and acute beds at York Hospital and none in ITU. A little bit more up-to-date data as of today is reporting that we currently have 1 person in ITU, but no people anymore in general and acute beds at York Hospital. This slide talks about excess deaths. So far in the pandemic in York, we've seen sadly 395 people who have died from COVID since the start of the pandemic. This slide is trying to compare the number of people who have died in total in York from any cause, and also does show the COVID deaths, in order to demonstrate that that measure that we talk about, which is the excess death rate, the number above what we would have expected to see if you take a 5-year average. And as the slide shows, we've had 168 excess deaths since the start of 2020. So 168 more deaths than we might have expected looking at the average. To cover the situation in care homes and schools, we've had, as of the 29th of April, there were no care homes with confirmed infection, and there hadn't been an outbreak since the 25th of February in a care setting. And an outbreak is defined as 2 or more cases, and that stays as an outbreak for a 28-day period. So that was when we had the last 28-day period finishing for the City of York in a care home which had an outbreak. We have had, since this data was put together, 1 staff member has tested positive at a care home through lateral flow testing, but as of the point these slides are put together, we had no cases. This just shows how it works through the age bands, and I think what this really shows, similarly to previous data, is that in many ways we've managed through vaccination primarily to bring the rates of our over 60s population down really dramatically. And this would have been a very different slide this time last year, in which we were just entering the pandemic and had no vaccine. And of course, people were getting COVID generally the same sort of rates across the age band, and those over the age of 60, that much more at risk of a poorer outcome. And to see rates where, I mean, we've had weeks in the last month or 2 where we haven't had any over 60s getting COVID, that's a very positive thing. In many ways explains the reduction in the number of people in hospital and dying from the disease, and that really is a vaccination related trend, and it's very good to see. This just shows across our wards. A few months ago, we were following ward-based data very closely, and we're taking some steps around deploying testing units to specific parts of the city and making sure that the tests we had available were targeted towards. At the moment, as you can see, we have a spread. Some wards haven't had any cases in 7 days. Some have had 1, 5, 1, 5, 3, as you can see on this sheet. And actually, I think what it goes to show is that the remaining COVID cases are fairly well spread across the city and are not clustering in any one place. We have probably seen over the course of the pandemic more cases in deprived areas in York cumulatively, but at the moment it's fairly well spread across the city in terms of its wards, and no real geographic clusters. Move on very quickly, aware of time, to talk about vaccinations. This chart talks about the proportion of the different cohorts under the JVCI, cohorts, priority groups for vaccination, who have been vaccinated both first dose in the blue and then orange the second dose. And as you can see, for our over 70s, all 3 priority groups, we've seen over 90% of the over 70s vaccinated for both their first and their second dose. And for all of these priority groups that are listed, so this is 1 to 9 plus 10, and as in our 40 to 49 categories, we actually have over 50% having their first dose, and for most of those categories down to 50, it's 88 and above. And April and into early May really has been second dose month, and our second doses have been catching up and we're seeing great progress in that regard as well. We contact trace all COVID cases from the public health team since the middle of March. That has been at hour 0. It used to be at 24 hours. Now the cases are directly handed to us from Public Health England. They don't have any involvement anymore in tracing the contacts. We call every case and offer the isolation advice, make sure people know what the guidance is, but also crucially trace their contacts and get in contact with them through National Test and Trace system in order to make sure that they are following the advice and guidance. This system only really works if people adhere to the isolation advice and guidance, and we know that that hasn't been universal, and there is still a really strong public health message, and there will be, I think, throughout this year, that it is very important if you've been a contact of a COVID case or if you have symptoms that you should isolate, you should get a test if you've got symptoms, and you should look to stay away from others and isolate at home for the 10 days if you've been testing positive. But it's very good to see that our local contact tracing team are having real success in reaching people and spreading that message. The roadmap, this has been produced for our work in terms of reopening the city centre, but just to reiterate to colleagues and those watching on the live stream that we are in the middle of stage 2 as a nation. So currently we have the rule of 6 for outdoors or 2 households mixing. As of the 17th of May, we're obviously moving into a time where 2 households can mix together, and 6 people can indoors, and outdoors it's up to 30, and we have some limited opening of outdoor and indoor entertainment, and then stage 4 into 21st of June. And I think it's important as we move on to this last slide just to recognise that we're going to have to learn to live with COVID and some measures which are likely to continue, and to be very clear with people that the roadmap is there for a reason. It is also provisional, and it has within it a 5-week window between each stage, and in the last week case rates are being looked at. There are 4 tests the government is looking at, so they're looking at the infection rate, they're also looking at the vaccine programme and how on track it is with the schedule that we set out, looking at whether it's reducing deaths and hospitalisations, which it is. It's also reducing transmission, and some recent research on that has been very positive about the reduced rates of transmission, and looking at the variants. And people will be aware that several postcode areas in London recently have been asked to surge test, so ask all households to take asymptomatic testing. We have a surge testing plan in place for the city. We are awaiting the call, I expect, on a Friday evening at about 6 p.m. or on a bank holiday Monday or some other really convenient time like that to tell us, but we are ready to go with a surge testing plan if a variant of concern is picked up, to get testing out. Variants under investigation, such as the India variant, are being looked at actively, but they wouldn't necessarily trigger surge testing. And this slide just summarises other aspects of living with COVID and other aspects of the recovery for the city, I guess, in general, thinking about items really covered already in the agenda, the restoration of NHS services and the waiting list and elective care that we need to catch up on is obviously a priority for the city. Impacts on children and young people of the pandemic and on mental health already covered, and on those from our older age ranges, and really that key message from Michael Marmot of the report that was produced before Christmas, that need to build back both better in terms of public services, but also fairer, and some of the inequalities which have come out during the pandemic, which we discussed at the workshop last week. So, Chair, I'll hand back to you, and I'll stop sharing my screen and ask for comments.
Thank you, Peter. That's good spread of information, mostly positive, which is nice. We've got some questions coming in. Just to say to people from the different services, if you wish to give an update after the questions, this is the time to do it. Councillor Orrell. Keith.
Thank you, Chair. Couple of questions, Peter. I think there were 4 children tested positive in schools. How many other children did that affect? Have you any figures on that?
So, Councillor Orrell, it's not necessarily that they're testing with a contact within school. So I don't have the precise details on those 4. We have seen a few bubbles close since the start of Christmas, but really a very small number, and no whole school closures since the wave that we had after Christmas. And we've seen, of those 4, for instance, some may have been picked up because on the data they're of school age, but actually they weren't in school during any contact period, so there might have been no need to isolate in terms of bubbles. It might have been, for instance, over the bank holiday weekend recently. So I can't specifically comment on the effect of others within the school environment, but what we do know is that when we have a case within the school, all of our schools have become very adept at doing that contact tracing, looking at what constitutes the contact, and sending bubbles home as and when that's required, but hasn't been required as much as it has in other areas, actually, because I think our schools have done a really good job at some of those prevention measures, trying to keep the bubbles as small as possible, and that is not always very easy. And as and where it has been necessary, we have had to isolate whole classes or whole bubbles, year groups. For secondary school pupils as well, it is often slightly easier to keep them socially distanced on school premises in a way that primary it's not. So there is a bit of a difference as well between secondary and primary there.
Thank you. The other thing, Peter, I think there was a report either yesterday or the day before from Darlington of a large number of non-attendance for vaccinations. Have we had anything similar here?
It's again it's a good question, a very key question. I think that we're going to have to be asking ourselves for the years ahead, because COVID vaccination is likely to turn into an ongoing program with boosters, and I think about other immunization programs I've been involved in, like MMR. We've always had lower than 100% uptake, and it's always been that question about how you engage with people well, help answer their questions around why they haven't taken it up. We often talk about the 3 C's within vaccine programs, so people's confidence in the vaccine itself, and some people have worries about getting vaccinated, the convenience of getting the vaccine, so the access to the place that they're able to. Do they have transport? What about childcare? That sort of thing. And then complacency. Some people who just don't think it's important enough, and there will be a mix for some people of all 3 of those. And I think we are working quite hard to try and combat that. I do think there will have been some people in York who have refused their vaccine. We know primary care has reported, there have been some phone calls where they've phoned up to book in and people haven't wanted to take it up. There have equally been others who have been offered and haven't followed the link to go to the website, or haven't booked on and called the number. And there was quite a lot of active work happening in York and wider, actually, about that, particularly thinking about my team, Public Health and the Council. We're now working very closely with the GP practices in York on a project we're calling Vaccine Tracing, where actually we are actively phoning up those who haven't attended and have probably had quite a long time so we've started with the top cohorts who were invited quite a while ago now, to have what we hope is a really sort of helpful and friendly conversation to try and encourage them to get along to the vaccine clinic. The staff who are doing that have been the contact tracers, so they've become very adept at those tricky conversations with people who about COVID and about self-isolation, using those skills to try and engage people in conversations about getting vaccinated. That's a very early stage project. It's only been going for about a week. So we don't have necessarily any huge outcomes from that to start with. We're working on how that proceeds and looking to learn the lessons from it. But I think it's a really good way of engaging people in conversations if they haven't taken it up. So there's lots of other initiatives. I know Steph is on the call today, who probably has a whole raft of things in her head as well around vaccines and trying to increase uptake. But that's, I think, one thing I'd highlight.
That's a good initiative. Yes, thank you. Stephanie Porter from the CCG, would you like to comment?
Yeah, just to expand a little on that. We've seen good take up, and as we go through the ages that become eligible, obviously what we see is a surge of the most interested people coming forward to be vaccinated. So that keeps our numbers high. And then we work with primary care just to identify those things that might be barriers for the smaller numbers who haven't taken it up. Now, we are probably more sensitive to imagining that the younger age groups are going to have more reason to want to rearrange or not take the offer up on the first occasion. As I say, as we've been going through the younger age bracket, we haven't experienced that yet. But I think as it becomes a smaller group of people, we'll just work increasingly harder to make sure that people know that that is an offer that they can take up. You've perhaps heard me say before, you know, the contact tracing is gathering all sorts of knowledge and experience about why people may choose not to take up a vaccine, and lots of those things are legitimate as well. So that balance between supporting people's choice versus getting the numbers up is the approach that we want to take. But we haven't necessarily seen people not attending, but we are more sensitive now to making sure that we understand the offer to younger people, and particularly as we get into a working age cohort, the flexibility that we probably need to be aware of with them wanting to change appointments. What I would say is that it becomes a really complex logistical issue. First vaccines, second vaccines, 3 types of vaccines, 12 weeks apart, those people who perhaps need to come forward because of health related conditions. So, you know, I know we talk about what a phenomenal job the vaccine centres are doing, and that really does go without saying. But as we move towards a very complicated picture with different vaccines and making sure that people are coming, and lumpy supply, still, you know, it really is a phenomenal effort from everybody in the city to make the programme work.
Yes, it is, Steph, and thanks go to all of the people involved. And it's not just the people giving the vaccines, it's the everybody else's, isn't it? Yeah. Anna is next.
Thanks, Chair. I'd echo those thanks as well. I just wanted to check in with you, Peter, and probably you as well, Stephanie, about the people that aren't taking up vaccines and the reasons. And I suspect that the sorry, I'm just looking at my note. What it was called, the vaccine tracing project, is probably a response to that, isn't it? And sort of certain groups that weren't doing it. But are we making progress, and do we know sort of what the reasons are that people haven't done it, and how we're going to go about getting a vaccine to those people who aren't necessarily getting to a vaccine centre themselves?
So maybe I can come back on that,
Yes,
and
Steph,
then
you can.
it might
Yeah.
flow into Emma's comments. So early days for the contact tracers, and they're working down the ages. So we work on data, and the data's not always right. So those people who've declined, we've got a surprisingly high number of people who've not taken up a vaccine because they're not resident in the UK. So, you know, it does go through quite a long list of reasons. Some people are too ill to take the vaccine, some of it's choice. So we do have a growing body of evidence, and I would just also say that one of the reasons why we do the contact tracing project is actually our practices will have invited people 2 or 3 times, multiple invites through different mediums, as well as the national press. So we've put in place transport hardship fund. So there are mechanisms if some of the responses are, I can't get there, I can't get to Askham Bar. So there are mechanisms in place to do that. We continue to review the options around taking the needle to the patient, so reviewing pop-up clinics. So I think it's quite a rich picture, but as you get down to smaller numbers, you're almost looking at a bespoke offer for some people. But in the data, what we're finding is when you're looking at the smaller numbers, the data is not always telling you what you think it is telling you. So a patient may appear in multiple lines. So they could be a health member of staff who's in the 50 to 60 bracket, and possibly might also be a higher COVID risk. So yeah, I think we're cited on that, and we're working through those groups, and our GP practices are probably continuing to cleanse their data, identifying those who haven't taken up, and they know those cohorts now. I mean, they're not cohorts, are they? They're individuals, because we're in that sort of number of groups, really. So we are responding to individuals, and our numbers are very high. We say a cohort's completed when we reach 90%. That's our sort of our working theme, but we talk about the vaccine offer being evergreen. So just because you said no at the first, second or third time of asking, there's still an option. So our social media is really just continuing to reiterate that. Finally, we're doing more work with seldom heard groups, and that's just now starting to pick up. So we've worked with a number of community leaders, really, just to make sure that we're getting our messaging right. So I think we've had reasonably good success, and we're just moving through the age brackets to flex our approach that's right for the individuals.
Thank you, Steph. Emma looks as if she wants to comment, which isn't surprising. From the GP's perspective, Emma?
Yes, thank you, Chair. Oh gosh, I'm probably going to back up just most of the things that Steph's gone through, but I guess I'd like to say, obviously, thanks to the primary care community, because they have done an amazing job to step up to the plate. And we've been very lucky in York to get that mass vaccination hub, and Nimbus Care were really ahead of the game to go for that national recognition to get the hub funded. So we've been very lucky in York. And I think my experience, and most of us would echo, is that the demand outstrips the supply still. So I guess my message to the public is, please bear with us. We don't have enough vaccines for everyone that's been offered them as yet, but they will come, and they are coming, and there is a very good booking system in place. But as they come through, we are, as I say, demand outstripping supply. There have been two interesting sort of perspectives. One, from the elderly, the appreciation that obviously it reduced their COVID risk and the harm. And from the younger cohorts, there's obviously the desperation to be able to go on holiday. So I think we are seeing actually younger groups wanting to engage with the vaccine because they see this as the vaccine passport, the way out of the system. So I think globally, we've just been overwhelmed with the demand and desire for the vaccine. To back up what Steph's been saying, obviously, all my GP colleagues, we have been given a lot of rich data about our vulnerable cohorts, because of course we've been very concerned about the learning disability community, the autism communities, dementia, the vulnerable groups for whom perhaps their non-attendance doesn't reflect their declining the vaccine, but more their difficulties in either getting there or needing a special accommodation. I know Nimbus Care have put on a special learning disability and autism session where there is much quieter, smaller numbers with sort of, some preparation in advance to really try and look at that community. And as general practice, we have put on a ginormous campaign to get out to anybody that's housebound. If there are difficulties, we will go to take the vaccine to the patient. And we've had a real success in primary care in doing that. So we've looked at the vulnerable cohort. So just to reassure the public, that has been a real priority for us. We've been through all sorts of issues, IT issues, booking issues, but ultimately we've worked our way through most of those, and with support from the whole system we've got there. I think the final thing just about the access, so we've been very lucky to have the hub, but we appreciate a lot of people in York don't have transport or find it difficult to get there. And I'm aware that some of the community pharmacies now are going to be getting status in the next month. So hopefully in some of our communities with more deprivation, less transport, that there will be more vaccines available at a local level, which again should help the uptake for some of those communities. Thank you.
Thank you, Emma. Beverly, do you want to just give your bit of information?
Yes, I just wanted to add, from the sector I represent, care homes and domiciliary care, great thanks again, a massive important job. But also to highlight a gold meeting that we have every day as a system, absolutely looking at what we might be able to do right down to individual person need around vaccination. And that's something that's been really positive, working in line as an escalation route, so that the people who are delivering the vaccinations can have a route through for some of those really individualised needs for some of the people in the community. And just to note that Health Watch England have just produced a report on vaccinations and public perception, if anybody might be interested in looking at that.
Thank you. Simon, you next.
Thank you, Chair. Only very briefly, really. I mean, Peter covered the numbers, and we have indeed only got one COVID positive patient in all of our hospitals as of today. I do want to echo everybody's comments about the fantastic achievement around the vaccination programme, and in particular all the efforts of primary care because to some extent that is one of the key reasons why we've got such low hospitalisation figures now, and long may that continue. Obviously our attention now is focused on recovery and concentrating on those longest waiters and those of greatest clinical need, and that's what we're working on now, and included in that is obviously recovering all of our cancer work. It is worth pointing out that sort of demand levels of non-COVID work are rapidly getting back to normal levels, so attendances at TD and our referrals from primary care are back to the levels of where we would expect them to see, and that is a good and positive thing, because clearly there's quite a lot of unmet need out there from the last year that will need to find its way into the health system, primary, community and secondary care. So effectively that's the focus of our attention. Hopefully for the remainder of this year we can all keep our fingers crossed that if indeed there is another wave, that we manage to make sure that the serious consequences of COVID are minimised as best as we possibly can. And I think, as Peter pointed out, it looks as though we will have a system of booster vaccinations that will come on stream later in the year, which will help us maintain the good level of progress that we've made to date.
Thank you, Simon. There's interesting things in the chat at the moment. It seems that Beverly has resurrected her training as a nurse and has been a volunteer vaccinator, which is just tremendous. And Emma reminds us of all the marvellous volunteers who usher you in and out. Certainly when I went to be vaccinated, they were doing a brilliant job, and I greatly respect what they do. And she rightly said the centres wouldn't be able to work without them. Is there anybody else who would like to make a comment or give any updates at this moment? I think we've probably had most of them during the session itself. Peter, any more comments from you to bring this to a close?
No, thank you, Chair.
Thanks very much, Peter. Right, in which case we'll move on to the next item, item 7 on page 49, and this is the Better Care Fund update. I'm a great fan of the Better Care Fund. I think it does immensely important work. And I think we've got Pippa Corner and Liz Allen to speak to us. So Pippa, would you like to start?
I will do. Thank you, Chair. And I'll do my bit, which I think is a bit of the boring bit, and then I'll introduce Liz, and that'll hopefully be the sort of main part of our conversation this evening. So thank you for having me. For people that haven't met me or heard me speak before, I'm Pippa Corner. I'm the Assistant Director for Joint Commissioning for City of York Council and Vale of York CCG. And in my role, I look after the Better Care Fund. I provided a written report which for long-standing devotees of the Health and Wellbeing Board will look very familiar, sort of standard report that should be self-explanatory. And there are 4 elements in it. One is around the national reporting process for the year that's just closed, 2020 to 21. The work that we've been doing to review the Better Care Fund. Some good news about a national small grant scheme that we were successful in our bid alongside North Yorkshire, and also a word about the planning arrangements for the current financial year. And if we had Sean Jones still on the call, we might have grilled him about that, because in essence, we don't have the policy framework at the moment, and we'd love to know when it's coming. I'll just sort of draw attention to the fact that there were 4 recommendations, which are very straightforward and very familiar for most members. So one was to receive this report for information. One was to delegate authority to you, Chair, on behalf of the board to sign off what will be our end of year expenditure return for the year that's just finished, because the deadline is the 24th of May, so obviously it falls between meetings. I would be glad if members would note progress on the Better Care Fund review, and also receive a further report in future about the conclusion of that, and then future reports. So I'm hoping that the report itself, as I say, is self-explanatory for anybody who's not too familiar. The National Small Grant Scheme was released during March, and we were able to successfully bid for £15,000 to pilot an innovative model of care called Care Rooms Limited, where it's a way of helping people who need a little bit of support if they come out of hospital, potentially after some elective surgery like a hip replacement or something like that, who don't perhaps feel quite ready to go straight home, but we don't want to put them into a care home. And we're just getting that pilot off the ground now, and very glad that colleagues have joined a sort of support network for the provider, and including Bev, who's here this evening on behalf of the Independent Care Group, is going to also be part of that reference group. So it's very much a supportive, collaborative network around the pilot. So if I can just then take us to the slides, if that's okay. Is it Joseph? Thank you. So if we just move on, as hopefully people remember, our vision for integration is all about collaboration and the way we work together to prevent people deteriorating and to improve our innovation and communication. So if we move on again, just a quick reminder that it's all about seamless services, preventing ill health, and making sure that people get the right care in the right place at the right time. And again, please. In the year that's just finished, the Better Care Fund for York was almost £20 million, so over £19 million of value for the city. We had to roll forward plans because of this sort of hand-to-mouth planning from a national perspective, and as I mentioned there, we've got an expenditure return to submit later this month. Members of the Health and Wellbeing Board previously agreed to have a full review, extending schemes until the end of June, so that we can actually take a really close look and make sure we're getting the best value out of them and set direction for the longer term plans as we go forward. And Peter here has been a core member of the reviewing group, helping us think about what does value mean and how can we make sure that we use the Better Care Fund to particularly work on prevention and tackle inequalities and tackle isolation. So the following slides just to cover the progress. So we have now completed the sort of first 3 phases, which were about looking at all of the schemes one at a time and thinking about them against the same set of questions. And we've got annual evaluation sessions this month, which we've been having for the last few years, where we bring schemes together to compare notes and to look at further opportunities for collaboration. So we hope that with those 3 sessions happening alongside the review that's taken place, we should then have a really good way forward for longer term strategic recommendations, which will come back in July. So some headlines. Yes, the schemes have demonstrated their real value to the system, and it's especially through their interconnectedness and collaboration. We've talked quite a lot about value for money, but also social value and social return on investment and the individual outcomes and prevention. And alongside that, really trying to think about population health improvement, and that all those things count as currencies within our system. So where we had the Health and Wellbeing Board workshop the other week looking at population health and tackling inequalities, Better Care Fund is it's a really good platform for us to focus our resources in that direction. The review is giving us a bit of a baseline, but we know that we can do more to measure activity and costs, and we're going to use our performance framework, which has come a long way over the last few years, to help us do that. Just in the slides that follow, there were some key headlines for commissioners and scheme providers. If we could just move on. Thank you. We've certainly recognised that we could clarify our business processes and improve communication between commissioners and the scheme providers, and we can simplify some of the sort of accounting around the budget, the finances, and we can join up our arrangements between the council and CCG, because some of the funding streams are quite tangled, and we think we can support schemes to operate more efficiently. And also we can improve awareness and understanding about really the history of the Better Care Fund, and in particular the fact that we have some schemes which are 100% funded by Better Care Fund, and therefore I feel we almost own those schemes, and it's our role to really nurture them and challenge them and move them on. And then there are some where Better Care Fund makes a contribution, so we're more of a stakeholder, and we might want to influence some of those big budgets to go towards prevention and towards tackling inequality, but we're not the only stakeholder. Thank you. So there were some actions for the schemes. Each one has some specific recommendations that we've discussed as we've gone through. We want to capture more information about how people use the schemes, what sort of activities delivered and what outcomes we're getting, and to further develop our performance framework. We are already collecting a lot of case stories, and I'm sure Liz will sort of set the discussion alight really with some good examples of the work that the York Integrated Care team do, because that's how we understand the purpose and impact of the fund. We think that we can target resources to the greatest need and address health inequalities, and particularly thinking about prevention objectives, but also thinking about some of those parts of our community that as a colleague referred to earlier, can be seldom heard. Sometimes, you know, people have referred to them as hard to reach, but we want to see if we can really reach out to all communities through the fund. Definitely expanding collaboration as integration, and we've got some specific areas that we think we need a more strategic approach to that would be across the whole system, starting with intermediate care. So we'll be doing some work on intermediate care as a system, and that will be one of the features of that report in July, one of the sort of slightly sort of more detailed recommendation around that. I think there's one more slide of headlines. So as I said, we've got a short list of actions for each scheme for both providers and commissioners that will improve our day-to-day management. We want everybody really to focus on further collaboration, think about improved reporting on costs and activity, and also use the annual evaluations this year to specifically look at tackling inequalities and demonstrating value, and really trying to enhance our understanding of what value means and the different types of value that we believe in, but also to be able to articulate that better. And as I talk to colleagues and partners outside of York, I think this is quite interesting work that is quite new, thinking about the concept of currencies and trying to get beyond just a simple value for money calculation. Now, I think that's probably the end of the slides, if I remember rightly. Yes, so we've talked about integration quite a bit. We've done that by building relationships and collaborating rather than by structural change or organisational boundaries. Just move on again. And I've talked about the next steps. So we'll bring together this whole system. We're going to be prioritising our resources and working on a strategic approach to various service areas. And we're going to try to make sure that Better Care Fund develops as a real key platform for prevention and population health management, and will be a real asset for the Alliance as it develops and for York as a place. I think I really have reached the end of the line there. Okay, thank you. Thanks very much for doing the slides for me. So I would like now to introduce Liz Allen. Now, Liz, I think I get it right if I say you're the manager of the York Integrated Care Team, and I'm really thrilled that you've given up some time to come this evening to see the Health and Wellbeing Board in action, but also to share your sort of first-hand account of the work that you do. Thank you.
Thank you, and thank you for having me. And I must say I am very nervous, but also the fact that some of the topics covered this evening, actually the York Integrated Care Team are very involved with. So the York Integrated Care Team was a pilot that started 7 years ago this month, and initially it was just for primary medical group, but within 12 months we were looking after and supporting all the surgeries in York, all the practices in the city of York, excluding Alvington, and that isn't through any choice. They have been offered the service, so it's just to make that clear that so at the moment, it's all the other practices within York. We started as a team, again, with all the aims were very similar to the Better Care Fund, and we are fully funded by the Better Care Fund. And it was really to deliver person-centred care, prevent unavoidable hospital admissions, expedite safe discharge, and to try and coordinate somebody's care. So if we become involved to coordinate. And initially some tools were run so that we got our original caseload of patients, but we realised that that didn't always pick out the correct people, because sometimes if they've been going in and out of hospital, it was for treatment that they needed to go out in hospital for, so for cancer treatment, dialysis, etc. So to make it, we have daily MDTs, and from that was how we selected, and that sounds awful, the people that we would offer the service to. We do offer, they can decline, very rarely do they decline, but we'd ring after they come out of hospital to offer. We also get referrals from GPs, district nurses, anybody and everybody we would take a referral from. And if we're unsure, then we'll add it to the MDT, where we have our nurse, therapist, social work, GP, to discuss and see if they think that's appropriate. And when we say appropriate, it is, can we offer anything to help? It isn't that we're not wanting that person, but can we make a difference? And if we can't, can we signpost to other areas who they may be able to make a difference to the more appropriate service? And so we do a lot of that for GP referrals when they ring in, because sometimes it might not be for us, but we try and help them navigate the system. So we have really grown over that time. And then in the first 9 months, we also picked up what we call our healthcare support. We got additional funding stream for that. And that was to support the additional hours that the rapid assessment team in the hospital A&E had to support short-term care. But instead of just utilising it for that, if we have any spare capacity, then we offer it to anybody. So if anybody needs a discharge or if a GP refers in, so we could utilise to prevent an admission. We had it under our own umbrella, and there was no really strict guidance, and somebody needed some additional support for a few days, then we will do our utmost to facilitate that. The daily MDTs are quite a big focus. We look at every over 18-year-old, every admission and discharge for the whole of York. That is a massive piece of work for a couple of our ladies in the office, as well as answering the phone. And we've actually amended how we look at that. And then we're now looking at the frailty score, because our lead nurse, Jo, is working with Peter Roderick and others and looking at the frailty and how we code within the general practice. So we try and pick up on initiatives that are going out and about and see if we can provide that data and support with other pieces of work. We've worked very closely with all GP practices in providing nurses that are attached, that we within our team, to do at least a day's vaccinating a week. So we've supported with the housebound vaccines, the care home vaccines, the learning disability home vaccine. So if somebody's being short of staff, then we've just stepped up and we've sort of offered a day wherever to support with that. The bonus for that is if we've been doing the housebounds, we've sometimes come across people that we don't know, that aren't on our register, but when we've actually gone in, we think, they're in a little bit of a pickle. So what can we do to help? So we've offered them while we're in there, and then visited at a later date with our other hat on as a York Integrated Care Team nurse to see if there's anything there that we could do to support. Again, COVID has thrown some challenges at us, and we had to alter how we worked last year. And a lot was through telephone to start with, because people didn't want visitors. They were very anxious. We were willing to visit if necessary, and we have done a lot of visiting where others haven't. If we've had a frantic phone call, then we went out and supported. Our healthcare support have also been doing those visits. Along with that, though, we also noted that there was a difference in some of our patients. So some that we can sort of follow up by telephone, but also we've noticed that things are changing, all the long COVID, all the mobility issues, everything like that, that Peter mentioned earlier and other people have mentioned. And we are picking up on that. And when we've recruited, because we had a couple of vacant posts this time, we've actually recruited mental health nurses to broaden the spectrum within our team so that we have a more diverse team that can support one another with their different expertises, which is what we do. And we've also put a bid in as well to the BCF, again, for some more monies for a physiotherapist. We have an OT, but we don't have a physiotherapist. And we feel with the mobility issues that are now going to be prevalent, and to keep everybody safe and to keep our healthcare supports safe by doing that, that having a physio within the team that can react when somebody's out there, then they go out. We are very responsive, and we actually have a telephone line that comes direct to us. We're very against having an automated service or one that's a central, really. We man the phones ourselves. Any member of the team could pick up the phone because they want to speak to somebody, they want to get through to us, and we support them with anything that we can. I have found that I've done a little bit of supporting of people who were in step-down beds, had the vaccine in one place, has now gone home, but no surgery, nobody knew where they were going. So really sort of being the go-between, because they were maybe in a step-down bed, had the vaccine there by that surgery that just covered that home, which wasn't necessarily their surgery. They're now home again, but nobody, it's just sort of coordinating that and enabling either them to get to the vaccine hub and help with the booking and the booking of transport, or to get them onto the housebound list to be seen at home, which we've been supporting all the surgeries with. So we know the coordinators to be able to ring and say, this person wasn't on your list, now needs to be on your list. And it's sort of just that general coordination. We do all sorts, and might not like how we're spending money actually, but we have taken somebody who with dementia, her dog to the vets because it had a tumour and she couldn't sort it out, and got it sorted with the PDSA because she was more distressed about it. Every time she saw it, she got really upset. We have just recently, one person rang in crying, an elderly lady, and she was more because she couldn't put her bins out and the bins weren't getting collected. So we fed that back to the council, got them so that they would go up to do that. I think just simple things, as well as her health needs. It is, we look holistically. We meet daily with the social services. Later on in the day, again, what we call the one team. So there's ourselves, the reablement team, the community response team, and social services. And if we've got anybody that we're struggling with, we all discuss it and see who can do what, who can help. Can we do a joint package? Can we do a joint package to get that person out of hospital? Can we do a joint package to keep that person at home? And Pippa knows, because it's my favourite term, anything is better than nothing. So if we have somebody at home and sometimes it can be very prescriptive, well, they need 4 visits at home because they can't manage. Well, actually, if we talk to the family or they haven't got anybody, we can put 2 in, we'll give them 4 when we can get 4. It actually prevents an admission, and also it puts them on our radar and we can keep checking in on them. A lot of our visits might be just for antibiotics. We have elderlies that can't get out. You find out they've got a urine infection because they're confused, but they have no family members to collect their prescription. Our healthcare support will go, count them, administer them, check they're okay, go back the next day, just to ensure. So it's the simple things sometimes that make the biggest difference. We've run plumbers, we've run BT. We had a lady who kept calling 111. And when we got to the bottom of it, she was illiterate, was this lady, and couldn't manage a mobile phone. That the family had got her because they didn't think she needed a landline. She couldn't manage that. So when her brother would ring for 111, they'd say she had COPD. Is she breathless? Yes. So they'd send out an ambulance, and all she wanted was a sleeve for her arm because she had edema. But they just kept sending ambulances because she couldn't manage her phone. It was by getting a BT phone reinstated. It can be anything. I mean, there's lots. There's lots of where they've got masses of medication, and we need to go in, feed that back, because if it's on repeat, it just keeps coming and coming and coming, and they haven't been taking it.
Right. Yes.
And they haven't been taking it. So it's looking at that, feeding that back to the right people, going into the house, checking they've got food in the fridge.
Yes.
Because
so I'm going to interrupt, Liz, because I know that you could keep us entertained.
I think so. Go on all night.
People might have lots of questions. The one thing I would say, which I think listening to you sums it up for me, is that you have all of that clinical and professional expertise within your team, but there's absolutely nothing which is beneath or beyond any of you. And whatever it takes, you'll do it. Isn't that right?
Absolutely. Yes.
Right, we've got some questions coming through. I think Emma was first.
Yeah.
Hi, Emma.
Thank you, Chair. I know Liz very well. I think what Liz is struggling to possibly describe is that this is the team that we go to. When you say, I need help, the response is, what would you like? And it's so refreshing. So for primary care, turning to the York Integrated Care Team, when you have somebody vulnerable in the community that needs help, they don't ask what their age is, their criteria. They say, how can we help? And it's an absolute asset to primary and community care. And they do deal with health and social care. So they have made such a difference. I think the other part, obviously the main part is care coordination, isn't it, Liz, that you deliver. The other very powerful thing is they do advanced care plans on an awful lot of our vulnerable patients in the community. And those care plans, which include ceilings of care, have made a massive difference. Our social admissions to hospital, which used to be as a GP, your hands were tied, this person can't cope on their own, you'd have no option other than to admit for a place of safety. Liz's team has now become that place of safety. So it's rare, apart from perhaps Friday at 6 o'clock, which is always the time we get these urgent care, but the rest of the week, you do know that there is a service there for York residents that when we say they need help, the York Integrated Care Team are amazingly responsive. And for general practice, This has reduced our visiting levels significantly, because when we go out, there's a health need. Whereas before, general practice would often be the ones trying to organise the plumber, thinking, I'm sure this isn't what I went to medical school for, but Liz's team will help. When we say this person is struggling to manage at home, Liz's team will help. So it's made a massive difference to primary care. It's reduced hospital admissions, and from everybody in primary care, Liz, we couldn't manage without you. So thank you.
Lovely, thank you. Bev next, please.
I'm afraid I'm going to be on the same vein. So Liz and I worked many years ago together, setting up the discharge hub at York Hospital, and we couldn't have done it without Liz, and we could not have done it because when Liz mentioned there's no boundaries. You know, often commission services have lots of specification and KPIs and boundaries, and you know, is that my job? Is that yours? Liz's team never did that, and she was the jam in the sandwich. And I'm glad I've had the opportunity some years later to say thank you.
Lovely. Peter next, please.
Well, Liz and I have only met very recently, so I haven't had such an experience so far, but it has been a pleasure to work with you, Liz, and thinking, I guess, a broad comment really about the BCF as a I guess an instrument, and in some areas potentially you could say, you know, more of a technical instrument than anything else, but I don't think it's been that in York. And I think both BCF and this specific example around the integrated care team, set us a bit of an example of where I from a public health point of view want us to move forward, and I think city partners do as well. That when it comes to funding, we think about York's pound, we think about the resources available, and we think less about the institutional boundaries between them. And I think the BCF fosters that, and we need to build on the work we've done with the BCF and take that approach almost across everything we do. And then when it comes to provision of services, we just assume collaboration. We assume that services are going to collaborate with other services, and again, those boundaries are not there. And we create the technical apparatus, if it is MDTs, multidisciplinary teams of people coming together around patient groups. If it is just sharing data better within the safe parameters, but actually for good patient care, you need to be able to see people's records. You need to be able to understand, a group of people in the city who have unmet needs that we're not flagging up yet. Public health needs to be able to get the data to find out who they are so we can start providing for their needs better. And thirdly, I think innovation. I think that as part of the BCF review group that I've been on, it's been great to see that we haven't, the schemes in the BCF, there are some really big statutory service beasts in there, some really big multi-million pound contracts that statutory services provides, and are really high quality, it's really good, but there's some smaller things, but actually quite innovative pieces of work that have been funded through the BCF that are no less valuable, not just straight jacketed to the statutory services around the table, but a lot of third sector involvement as well, a lot of trying to build some capacity in the third sector and enable the third sector to be the asset that it is for the city. So yeah, I think those things around sort of innovation, around collaboration, and around not thinking about my pot, your pot when it comes to the money. Yes. I think they're really well illustrated in the BCF in general and in this project. So it's great to see this. And thanks, Liz, for your contribution today.
Thank you, Liz. Sorry, we're going to have to stop in a second. Just to say, Naomi from Tuve said that she thought it was absolutely excellent, and Dr. Wells says it's a can-do service, and it very clearly is a can-do service. So I'm afraid I'm going to have to stop the comments there, but I shall ask Pippa if she wants to make a final comment before we go to the recommendations.
No, just really thank you, Liz, for coming along, and no need for nerves. You always set the room alight, so thank you once again.
It was just a great idea to invite her, Pippa. I'm very glad that you did. So thank you, Liz, and you did a great job presenting to us, let alone the great job you do out in the community. So we've got some recommendations to consider. We've got to receive the Better Care Fund update, and I think now you've realised just how valuable the Better Care Fund is. Delegate to me the authority to sign off the end of year expenditure, because as always, the deadline for that comes between meetings. Note the progress of the review of the final allocations for the VCF to ensure maximum impact on outcomes and to receive further reports at future meetings. Is there anybody dissenting from those recommendations, or are we all content with them? All okay? Good. Thank you very much indeed. Right, we've come to the end of what's been a very interesting meeting, and I'd like to thank everybody for their contributions. It's exactly the way that the Health and Wellbeing Board should be looking at the whole system, not bits of people in various boxes, but the whole lot together. And Liz, I think, was the icing on the cake tonight. So thank you very much indeed, everyone. And I'll look forward to welcoming you to the next meeting in whatever format we are directed to hold it, which, as I remember, comes in July. So thank you.